Basically, what this drug does, it's a radiopharmaceutical. It targets a new target in prostate cancer called HK2. That's very similar to HK3, which everyone knows more commonly as PSA. But the big difference between this target and PSA is that this target is membrane bound as well as soluble, whereas PSA is strictly soluble. This is first in human of an actinium-225 radiolabeled antibody that targets HK2. The trial was for men with metastatic CRPC, and the target population was those who had progressed through at least one ARPI. The trial was agnostic to prior chemotherapy use, but prior radioligand therapy was excluded. As you indicate, the primary endpoint of the study was finding the recommended phase 2 dose as well as the safety profile of the drug. Secondarily, though, we did look at anti-tumor effects. We had to go through an iterative process to determine the safest way to deliver this drug. We started out as a sort of routine dose escalation by cohort design, with a dose given every 8 to 12 weeks at regular intervals. But we found that there was emerging thrombocytopenia and interstitial lung disease with that regimen. So then we went to a capped dose at 500 microcuries, and that could be either given as 250 times 2 or 400 times 1. And we found that the safety profile improved. And by virtue of doing that, wanting to further optimize, we switched to an adaptive dosing schedule with just one single dose of 250 microcuries. And then only when the patient biochemically relapsed and the platelets had recovered would we give additional doses. And those were at 150 microcuries, but still respecting the 500 to 600 microcurie cap. And with that, we found that the drug was actually much safer. When we used that fixed dosing schedule, we had grade 3 and 4 interstitial lung disease at a rate of about 17%, and 2 of those patients died of ILD. However, on the new dosing schedule with the adaptive dosing schedule and also capping the dose at 500 to 600 microcuries, we have really seen no interstitial lung disease. And as long as we stay under that 500 microcurie dose, there is no ILD. And also in the new dosing schedule, the thrombocytopenia is also mitigated. So it's taken a bit of persistence in the phase 1 portion of this drug development to get to the safest dose and dosing schedule, understanding that there does need to be a dose cap, but I think that we have figured this one out. In terms of efficacy, though, because all safety is counterbalanced by an efficacy signal, what we found is at 250 microcuries and higher dose, that the PSA 50 rate, confirmed PSA 50 rate is 44%. The confirmed PSA 90 rate is 9% of the 17 patients with measurable disease. We found that there's a radiographic response rate of 18%. These can be quite durable. Even with a single 250 microcurie dose, you can have durable responses. We saw patients have greater than 4 months, greater than 6 months, even 24 months of response. In terms of the most durable response, we have a patient who's now out to 27 months. So I think that this drug now we know how to give this drug in a safe manner. We're seeing promising anti-cancer effects in this trial, and we plan to now explore this in the radioligand pretreated population.